Welcome to Pediatric Case Review. Today's lecture is a comprehensive case-based review of persistent pulmonary hypertension of the newborn, commonly known as PPHN. This condition represents one of the most critical emergencies in neonatal medicine, requiring rapid recognition and evidence-based management. We will walk through 15 carefully designed clinical cases covering clinical presentation, examination findings, pathophysiology, investigations, treatment strategies, weaning protocols, and long-term complications. This lecture is designed for general pediatric physicians and trainees. Let us begin. Case 1. A 38-week gestation neonate is born via cesarean section following prolonged rupture of membranes. At 1 hour of life, the infant presents with severe respiratory distress and cyanosis. APGAR scores were 3 at 1 minute and 5 at 5 minutes. Oxygen saturation is 78% on 100% oxygen via nasal cannula. Heart rate is 180 beats per minute and respiratory rate is 70 breaths per minute. Chest X-ray shows clear lung fields with mild cardiomegaly. Which of the following is the most likely diagnosis? Option A, transient tachypnea of the newborn. Option B, respiratory distress syndrome. Option C, persistent pulmonary hypertension of the newborn. Option D, congenital heart disease. The correct answer is option C, persistent pulmonary hypertension of the newborn. This condition results from failure of the normal circulatory transition at birth, with sustained elevation of pulmonary vascular resistance. The key features that point to this diagnosis are severe, often refractory hypoxemia, and cyanosis with poor response to oxygen supplementation, right-to-left shunting through fetal pathways such as the patent foramen ovale and patent ductus arteriosus, and onset shortly after birth with respiratory distress. Clear lung fields on chest X-ray with cardiomegaly in a cyanotic neonate who fails to improve on oxygen is a classic presentation pattern. Case 2. A term neonate delivered by emergency cesarean section due to fetal distress presents at 2 hours of life with progressive respiratory distress. Despite high-flow oxygen therapy, the infant shows concerning vital signs: preductal oxygen saturation of 92% and postductal saturation of 84%. Heart rate is 180 beats per minute and respiratory rate is 70 breaths per minute. A loud systolic murmur is audible. The infant shows poor response to conventional ventilation. Which clinical feature most strongly supports a diagnosis of PPHN? Option A, rapid heart rate of 180 beats per minute. Option B, preductal to postductal oxygen saturation difference of 8%. Option C, presence of a loud systolic murmur. Option D, history of fetal distress during delivery. The correct answer is option B, the preductal to postductal oxygen saturation gradient. A gradient of 10% or more is a hallmark sign of right-to-left shunting across the ductus arteriosus. This finding carries significant clinical meaning. It indicates elevated pulmonary vascular resistance and confirms persistence of the fetal circulation pattern. Preductal saturation, measured at the right hand, reflects blood that has not yet passed the ductus arteriosus. Postductal saturation, measured at the lower limbs, reflects blood mixed with deoxygenated blood shunted through the ductus. A gradient of 10% or more is clinically significant and should prompt urgent evaluation for PPHN. Case 3. A 39-week gestation infant born after meconium-stained amniotic fluid develops severe hypoxemia. The partial pressure of oxygen in arterial blood is 52 millimeters of mercury on 100% inspired oxygen fraction, with acidosis showing a pH of 7.21. The baby requires intubation and high-frequency ventilation. Despite optimal ventilation, oxygenation remains poor. Which of the following best describes the primary pathophysiological issue? Option A, alveolar hypoventilation. Option B, impaired gas exchange due to surfactant deficiency. Option C, persistent high pulmonary vascular resistance with right-to-left shunting. Option D, systemic hypotension leading to poor tissue perfusion. The correct answer is option C, persistent high pulmonary vascular resistance with right-to-left shunting. In PPHN, pulmonary vascular resistance fails to decrease after birth as it normally should during the transition from fetal to neonatal circulation. This sustained high resistance prevents blood from flowing through the lungs for oxygenation. Instead, blood is shunted right to left through two persistent fetal channels, the patent foramen ovale and the patent ductus arteriosus. This produces severe, refractory hypoxemia that does not respond to oxygen therapy alone, because the problem is not insufficient oxygen delivery, but rather blood bypassing the lungs entirely. Case 4. A term neonate presents at 3 hours of life with respiratory distress and cyanosis. On examination, The preductal oxygen saturation measured at the right hand is 96%, while the postductal saturation measured at the left foot is 88%. The infant has tachypnea with a respiratory rate of 65 breaths per minute and appears mildly cyanotic. A systolic murmur is audible at the left sternal border. Which of the following best explains the differential saturation pattern observed in this neonate? Option A, left to right shunting through a patent foramen ovale. Option B, right to left shunting through a patent ductus arteriosus. Option C, systemic hypotension with poor peripheral perfusion. Option D, total anomalous pulmonary venous connection. The correct answer is option B, right to left shunting through a patent ductus arteriosus. In PPHN with elevated pulmonary vascular resistance, deoxygenated blood from the right ventricle is shunted through the patent ductus arteriosus into the descending aorta. This lowers the oxygen saturation of blood supplying the lower body, creating the characteristic differential. Preductal saturation at the right hand reflects blood before the ductus and is therefore higher. Postductal saturation at the feet reflects the mixed deoxygenated blood and is therefore lower. A difference greater than 5 to 10% is clinically significant and strongly suggests right to left ductal shunting in PPHN. Case 5. A 39-week neonate born after prolonged labor develops severe respiratory distress at 2 hours of life. The infant requires intubation and mechanical ventilation. On auscultation, there is a loud, harsh systolic murmur heard best at the left lower sternal border that increases in intensity during inspiration. Preductal oxygen saturation is 94% and postductal is 86%. Echocardiography confirms elevated pulmonary artery pressures. What is the most likely source of this murmur in the context of PPHN? Option A, tricuspid regurgitation secondary to elevated right heart pressures. Option B, patent ductus arteriosus with bidirectional shunting. Option C, pulmonary stenosis causing right ventricular outflow obstruction. Option D, ventricular septal defect with left to right shunting. The correct answer is option A, tricuspid regurgitation secondary to elevated right ventricular pressures. In PPHN, the right ventricle works against significantly increased pulmonary vascular resistance. This pressure overload causes the tricuspid valve to leak backward, producing a regurgitant jet. The resulting murmur is characteristically systolic, heard best at the left lower sternal border, and its intensity correlates directly with the degree of pulmonary hypertension. The murmur may be accompanied by a right ventricular heave, which reflects hypertrophy of the overloaded right ventricle. Tricuspid regurgitation in this clinical context is an important bedside sign of significant right heart strain. Case 6. A term neonate with suspected PPHN is being examined in the neonatal intensive care unit. On physical examination, you palpate a prominent right ventricular impulse and observe a visible heave at the left lower sternal border. The infant appears cyanotic with tachypnea. Vital signs show heart rate 165 beats per minute, respiratory rate 68 breaths per minute, preductal saturation 89%, and postductal saturation 82%. A palpable right ventricular heave is present. Which of the following cardiac findings is most consistent with right ventricular hypertrophy in this neonate? Option A, a soft, blowing diastolic murmur at the apex. Option B, a narrow, fixed splitting of the second heart sound. Option C, a prominent S3 gallop rhythm. Option D, an increased intensity of the pulmonic component of the second heart sound. The correct answer is option D, an accentuated pulmonic component of the second heart sound. This finding directly reflects elevated pulmonary arterial pressures and right ventricular strain. In normal physiology, the pulmonic component of the second heart sound is soft because pulmonary pressures are low. When pulmonary pressures are elevated, the pulmonary valve closes with greater force, producing a louder sound. The intensity of this component correlates with the severity of pulmonary hypertension, making it a valuable bedside marker. Other signs of right ventricular strain in PPHN include the palpable right ventricular impulse, parasternal heave, and tricuspid regurgitation murmur. Together, these findings constitute the physical examination profile of right heart pressure overload. Case 7. A 38-week gestation neonate is born with severe cyanosis and respiratory distress. The mother used diclofenac patches for chronic back pain throughout the third trimester of pregnancy. The infant presents with suprasystemic pulmonary hypertension and a restrictive ductus arteriosus on echocardiography. Which of the following best explains the pathophysiological mechanism in this case? Option A, impaired nitric oxide production due to genetic mutation. Option B, increased pulmonary vascular muscularization from chronic fetal hypoxia. Option C. Premature constriction of the ductus arteriosus due to prostaglandin inhibition. Option D. Primary myocardial dysfunction leading to elevated pulmonary venous pressure. The correct answer is option C. Premature constriction of the ductus arteriosus due to prostaglandin inhibition. Nonsteroidal anti-inflammatory drugs, including diclofenac, inhibit prostaglandin E2 synthesis. Prostaglandin E2 is the key mediator that keeps the ductus arteriosus open during fetal life. When this pathway is blocked by maternal nonsteroidal anti-inflammatory drug use, the ductus constricts prematurely. This increases pulmonary blood flow in utero, which over time leads to pulmonary vascular remodeling with muscularization of pulmonary arterioles. At birth, this creates fixed pulmonary hypertension. This is an important clinical pearl. Maternal nonsteroidal anti-inflammatory drug use in the third trimester is a known and preventable risk factor for PPHN. Case 8. A 38-week gestational age neonate with severe PPHN undergoes pulmonary vascular biopsy analysis. Laboratory studies reveal significantly reduced expression of endothelial nitric oxide synthase in the pulmonary vascular endothelium compared to normal controls. Which of the following is the most likely consequence of this deficiency? Option A. Enhanced breakdown of cyclic guanosine monophosphate. Option B. Decreased production of endogenous nitric oxide. Option C. Increased sensitivity to prostacyclin analogs. Option D. Reduced systemic vascular resistance. The correct answer is option B. Decreased production of endogenous nitric oxide. Endothelial nitric oxide synthase is the enzyme responsible for synthesizing nitric oxide in the pulmonary vascular endothelium. Nitric oxide is one of the most potent endogenous pulmonary vasodilators. When endothelial nitric oxide synthase is deficient, nitric oxide production falls, and the pulmonary vasculature loses its ability to dilate normally after birth. This contributes directly to failure of pulmonary vascular resistance to decrease at the time of the neonatal circulatory transition, perpetuating the high-resistance state that defines PPHN. This is why inhaled nitric oxide is so effective as a treatment, as it bypasses this deficiency by delivering nitric oxide exogenously. Case 9. A term neonate with suspected PPHN undergoes echocardiographic evaluation. The study reveals a tricuspid regurgitation jet velocity of 4.5 meters per second, an estimated right ventricular pressure of 90 millimeters of mercury, a patent foramen ovale with bidirectional flow, and right ventricular dilation. Which of the following best describes the significance of these echocardiographic findings? Option A. Normal pulmonary artery pressure, indicating no PPHN. Option B. Mild pulmonary hypertension requiring close observation. Option C. Suprasystemic pulmonary hypertension indicating severe PPHN. Option D. Left ventricular dysfunction requiring inotropic support. The correct answer is option C. Suprasystemic pulmonary hypertension indicating severe PPHN. A tricuspid regurgitation jet velocity of 4.5 meters per second indicates very high right ventricular pressure. An estimated right ventricular pressure of 90 millimeters of mercury approaches or exceeds systemic blood pressure, confirming suprasystemic pulmonary hypertension. Key diagnostic thresholds to remember. A tricuspid regurgitation velocity greater than 3.5 meters per second suggests severe PPHN, and right ventricular pressure greater than 75% of systemic blood pressure indicates severity. Echocardiography remains the gold standard for PPHN diagnosis, shunt direction assessment, and cardiac function evaluation. This level of severity requires immediate intervention. Case 10. A term neonate with suspected PPHN is on mechanical ventilation. Current parameters are mean airway pressure 14 centimeters of water, fraction of inspired oxygen 0.8, and arterial oxygen partial pressure 60 millimeters of mercury. The medical team needs to calculate the oxygenation index to assess disease severity and guide treatment decisions. What is the oxygenation index for this patient? Option A, 18.6. Option B, 25.0. Option C, 30.0. Option D, 35.0. The correct answer is option A, 18.6. The oxygenation index is calculated as mean airway pressure multiplied by the inspired oxygen percentage divided by the arterial oxygen partial pressure. Using the given values, 14 multiplied by 80 divided by 60 equals 1,120 divided by 60, which equals 18.6. This result places the patient in the moderate severity category. The clinical thresholds are important to memorize. An index of 15 to 25 indicates moderate severity and warrants ventilation optimization. 25 to 40 indicates severe disease and is an indication to start inhaled nitric oxide. Greater than 40 indicates critical disease and should prompt evaluation for extracorporeal membrane oxygenation. Case 11. A term neonate presents with severe hypoxemia and clinical signs consistent with PPHN. The infant requires high-flow oxygen and shows poor response to conventional ventilation strategies. Chest X-ray reveals hyperinflated lungs with clear, expanded lung fields. There is no evidence of parenchymal disease or structural abnormalities. Heart size appears normal, and the diaphragms are flattened due to hyperinflation. Which of the following conditions is most likely to be associated with these radiographic findings in a neonate with PPHN? Option A, meconium aspiration syndrome. Option B, congenital diaphragmatic hernia. Option C, idiopathic PPHN. Option D, respiratory distress syndrome. The correct answer is option C, idiopathic PPHN. This is a critically important imaging pearl in neonatal medicine. Idiopathic PPHN often presents with clear lungs on chest X-ray, distinguishing it from secondary causes such as meconium aspiration syndrome, which shows patchy opacities, or respiratory distress syndrome, which shows ground glass haziness. The pattern of clear lung fields combined with severe, refractory hypoxemia should immediately raise suspicion for idiopathic PPHN. This paradox, that the chest X-ray looks relatively normal while the baby is profoundly hypoxic, is a key diagnostic clue that the problem is vascular rather than parenchymal. Case 12. A term neonate born at 39 weeks presents with severe hypoxemia at 4 hours of life. The partial pressure of oxygen in arterial blood is 45 millimeters of mercury on 100% inspired oxygen fraction. The infant requires intubation and mechanical ventilation. Echocardiogram shows a structurally normal heart with no evidence of intracardiac shunting and normal pulmonary artery pressures. Chest X-ray reveals bilateral diffuse infiltrates. Blood pressure is normal for age. What is the most likely diagnosis? Option A, persistent pulmonary hypertension of the newborn. Option B, total anomalous pulmonary venous connection. Option C, severe pneumonia. Option D, congenital heart disease with ductal-dependent circulation. The correct answer is option C, severe pneumonia. This case illustrates the critical importance of echocardiography in the workup of neonatal hypoxemia. A normal echocardiogram excludes right heart strain and elevated pulmonary pressures, effectively ruling out PPHN. The absence of shunting means the hypoxemia has a different etiology. Bilateral infiltrates on chest X-ray point directly to parenchymal lung disease. Severe pneumonia causes hypoxemia through ventilation perfusion mismatch and intrapulmonary shunting, which can mimic PPHN clinically but lacks the characteristic cardiac findings. The key clinical pearl here is to always correlate echocardiographic findings with chest imaging to distinguish cardiac from pulmonary causes of neonatal hypoxemia. Case 13. A term neonate with suspected PPHN presents with severe hypoxemic respiratory failure. Current parameters show oxygenation index 35, inspired oxygen fraction 80%, preductal saturation 88%, postductal saturation 82%, mean airway pressure 12 centimeters of water, pH 7.28, and arterial carbon dioxide partial pressure 48 millimeters of mercury. The infant is on conventional mechanical ventilation and remains critically hypoxemic despite optimal ventilatory support. Which of the following represents the most appropriate next step in management? Option A, administer oral sildenafil immediately. Option B, initiate inhaled nitric oxide at 20 parts per million. Option C, prepare for extracorporeal membrane oxygenation. Option D, increase inspired oxygen fraction to 100% and continue current ventilation. The correct answer is option B, initiate inhaled nitric oxide at 20 parts per million. Inhaled nitric oxide is the only therapy approved by the United States Food and Drug Administration as a pulmonary vasodilator for PPHN in term and near-term infants with hypoxic respiratory failure. The standard indication is an oxygenation index greater than 25, which this patient clearly meets with an index of 35. The recommended starting dose is 20 parts per million. Inhaled nitric oxide acts as a selective pulmonary vasodilator with minimal systemic effects, has a rapid onset of action within minutes, and has proven mortality reduction in clinical trials. The management algorithm flows as follows. Suspect PPHN, confirm with echocardiography, calculate oxygenation index, and if the index exceeds 25, start inhaled nitric oxide at 20 parts per million. Case 14. A 3-day-old term neonate with PPHN has been on inhaled nitric oxide at 20 parts per million for 48 hours. The infant is now clinically stable with the following parameters: inspired oxygen fraction 45%, oxygen saturation 94%, and stable, heart rate 140 beats per minute, blood pressure normal for age, and no signs of respiratory distress. What is the most appropriate next step in management? Option A, abruptly discontinue inhaled nitric oxide therapy. Option B, decrease inhaled nitric oxide dose to 15 parts per million. Option C, increase inspired oxygen fraction to 60% before weaning. Option D, add intravenous milrinone. The correct answer is option B, decrease inhaled nitric oxide to 15 parts per million. Gradual weaning is essential once the infant is stable with adequate oxygenation, defined as oxygen saturation greater than 92% and inspired oxygen fraction below 60%. The standard weaning protocol involves stepwise reduction: 20 parts per million, then 15, then 10, then 5, then 1, then discontinue. Each step is maintained for 2 to 4 hours to assess tolerance. The step from 5 to 1 parts per million is particularly critical because it prevents rebound pulmonary hypertension, which is a dangerous complication of abrupt discontinuation. During each weaning step, monitor closely for oxygen desaturation and return to the previous dose if oxygen requirements increase. Case 15. A 12-month-old infant with a history of severe PPHN requiring extracorporeal membrane oxygenation support during the neonatal period presents for developmental follow-up. The child was intubated for 18 days and received inhaled nitric oxide therapy. Current assessment reveals delayed motor milestones. The child is not yet walking and has difficulty with fine motor skills, and bilateral mild sensorineural hearing loss confirmed on audiometry. Which of the following is the most likely cause of these neurodevelopmental findings? Option A, persistent pulmonary hypertension itself as the primary pathology. Option B, prolonged mechanical ventilation and respiratory support. Option C, hypoxic ischemic brain injury from severe hypoxemia. Option D, underlying genetic predisposition to developmental delays. The correct answer is option C, hypoxic ischemic brain injury from severe hypoxemia. Severe PPHN requiring extracorporeal membrane oxygenation is strongly associated with long-term neurodevelopmental impairment and sensorineural hearing loss. The primary mechanisms are prolonged hypoxemia, severe acidosis, and potential complications from extracorporeal membrane oxygenation itself, including embolic events and anticoagulation-related hemorrhage. Key long-term complications include neurodevelopmental delays affecting motor and cognitive domains, sensorineural hearing loss, bronchopulmonary dysplasia, chronic pulmonary hypertension, and growth and feeding difficulties. An important clinical point: infants with an oxygenation index greater than 40 or those requiring extracorporeal membrane oxygenation have significantly higher rates of neurodevelopmental impairment at 18 to 24 months of age. Structured long-term developmental follow-up is therefore essential for all survivors of severe PPHN. Are you looking for a structured way to access all of our pediatric case-based lectures in one place? Our Pediatric Case review community on Patreon is designed exactly for that. All videos are organized by system, so you can easily navigate through the complete pediatric library and find exactly what you need. In addition to the videos, all presentation slides used in the lectures are available as downloadable images, so you can review and practice the questions at your own pace, anytime, anywhere. We also provide comprehensive practice questions to reinforce your learning with case-based content. If you are interested in joining and want to know more about how to subscribe, simply comment below this post, and we will message you directly with all the details. And that brings us to the end of today's lecture on persistent pulmonary hypertension of the newborn. Let us quickly review the key takeaways. Early recognition is essential. Look for differential saturations, refractory cyanosis, and clinical signs of right heart strain. Echocardiography and the oxygenation index are your two most important tools for diagnosis and severity assessment. Inhaled nitric oxide remains the first-line evidence-based therapy, and structured gradual weaning prevents rebound pulmonary hypertension. Finally, long-term neurodevelopmental follow-up is crucial for all infants who survive severe PPHN, especially those requiring extracorporeal membrane oxygenation. If you found this lecture helpful, please follow our Pediatric Case review channel for more case-based lectures covering a wide range of pediatric conditions. If you have any questions or would like a deeper discussion on any of the topics covered today, please comment below and we will be happy to help.